Hi, Dr. Carter. Welcome to Rio Grande Women's Clinic. The problem being investigated is, do Hispanic pregnant women who do not meet the criteria for the diagnosis of gestational diabetes mellitus, or GDM, have adverse maternal or neonatal outcomes? GDM is a global health concern, not only because its prevalence is high and on the increase, but also because the potential complications for the mother and the neonate include stillbirth, shoulder dystocia, large gestational age, respiratory distress, polycythemia, and admission to NICU. Methodology, keywords that I used in my research: gestational diabetes, GDM in Hispanic women, 1 abnormal value in the 3-hour GTT, obesity in pregnancy, ACOG, the American College of Obstetricians and Gynecologists, cesarean section, fasting plasma glucose. Databases: PubMed, CINAHL, and Clinical Key for Nursing.
In this article by McLaughlin, it was found that women with 1 elevated GTT value were at risk for maternal morbidities and having newborns with complications, to include high rate of C-section, chorioamnionitis, preeclampsia, and birth weight greater than 4,000 grams. Also, admission to the NICU. The level of evidence was 3. Limitations include that it was a retrospective study, the potential for confounding variables, and a number of patients with single abnormal GTT value was small. The strengths were that the sample size was large. The article by Meek found that using the UK's National Institute for Health and Care Excellence new criteria for diagnosing GDM will miss women with substantial risk of complications. The level of evidence is 3. Limitations are that neither NICE, the National Institute for Health and Care Excellence, or IADPSG, International Association of the Diabetes and Pregnancy Study Groups, are used in my clinical practice. The strength is that it was a large population base. The article by Facet showed that there was no benefits from treating women with 1 elevated oral GTT. Level of evidence was 3. Limitations include a small number of patients, a retrospective chart review, which may have unknown variables. Opinion by Visser found no improvement in outcomes if current ACOG guidelines for diagnosing GDM was changed to recently published international guidelines by the Hyperglycemia and Adverse Pregnancy Outcomes Group. Level of evidence 3. Metasynthesis. There are no limitations or strengths since this was an opinion. The article by Adain et al. Showed that GDM negatively affected cognitive development of newborns, primarily in the area of language. Level of evidence was 1, and this indeed is the first review of the possible effects of GDM on cognition. However, multiple issues exist with the article and review. The studies ranged from as far back as 1961. The current criteria for diagnosing GDM did not exist then. The studies used different developmental assessment tools, which made them difficult to compare outcomes. Confounding variables are not adequately or similarly dealt with. The authors do make clear that this study is a first step.
Using only the current ACOG guidelines for diagnosing GDM may lead to underdiagnosis of this condition. The implication for practice is to develop additional criteria to improve diagnosis and prevent maternal and neonatal complications.